Hi, I'm Dr. Rachel Pope. I'm a board-certified OBGYN who focuses on vaginal reconstruction, vulvar care issues, and sexual function and menopause. And I have a lot of patients who are going through perimenopause. My colleagues and friends, we started a support group for women in perimenopause and menopause. And one of the most commonly brought up topics is, how do I explain this to my partner? How do I explain that the irritability, the rage, all the other symptoms are not personal attacks on their partner, but there is something physiologically going on. There is science behind it. And how do I convey this in a nutshell? So I created this guide for partners. And just a note before we begin, this was written for the partner who loves a woman and wants to understand what's happening to her. It's not to fix her. It's not to manage her. It's to actually understand. And you probably were sent this because something has changed. Maybe it's been subtle. Sleep patterns are changing, mood changes are happening, and the body that your partner has been living in is starting to behave differently. And you, the person who is building the life with this woman, feels like this partner might sometimes feel unreachable. Maybe you've said the wrong thing more than once. Maybe you feel shut out, frustrated, or quietly scared that the relationship you've counted on is quietly unraveling. It's not unraveling. She's not broken. Your relationship is not unsalvageable, but she's going through one of the most significant biological transitions of a human life. And the science behind what she's experiencing is profound, complex, and almost entirely absent from conversations between partners. We don't want to see relationships ending because of a life change that is impacting them. So this guide is written with equal measures of clinical precision and direct, honest language. It really tries not to condescend to you. I don't want that at all. It also makes an effort not to infantilize her or make her like a patient, right? It treats you as capable of learning difficult science and applying it with care. And it treats her as a fully autonomous person moving through a real and sometimes brutal physiological event who deserves a partner who's informed and shows up. So the information following is grounded in current evidence. There's always more that we're learning. There's a lot of unknowns. So there might be things that change. There might be things that are completely different from how I'm explaining them now. So please grant me that awareness. And really, the goal is not to make you a caretaker. It's to make you a true partner. She's been navigating this probably alone, and it's time to change that. So let's start. What is perimenopause? Perimenopause is the transitional phase leading up to menopause, the point at which a woman has not had a menstrual period for 12 consecutive months, so a whole year. It's not really an event unless she really got there through surgery and both ovaries were removed at once, then that would have been instant. It is a process and it can last anywhere from 4 to 10 years. The average age of onset is in the early to mid 40s, but lots of women start to experience changes in their late 30s. The average age of menopause in the United States is 51. Women may begin experiencing perimenopause about 10 years prior to age 51. Remember, these are averages. So if a woman is going to enter perimenopause at age 48, she might start perimenopause as early as 38, okay? The central driver of perimenopause is the ovary. A woman is born with all the eggs she'll ever have, roughly 1 to 2 million of them. By puberty, that number has already declined to several 100,000. And through the reproductive years, each menstrual cycle consumes a small cohort of follicles. Follicles are the fluid-filled sacs inside the ovaries that contain developing eggs. As the decades pass, the ovarian reserve diminishes, and with it, the consistency and strength of hormonal signaling. The primary hormones involved are estrogen, progesterone, and to a lesser but critical extent, testosterone. The ovaries are the primary manufacturers of all three. As the follicle pool depletes, the quality and regularity of ovulation begins to fluctuate. Progesterone, which is produced after ovulation, becomes erratic first, and then estrogen follows. The result is a years-long period of hormonal variability that's so wide that standard laboratory testing frequently misses it entirely. This is the first thing partners need to understand. Perimenopause hormone levels do not decline in a smooth, predictable arc. They spike, crash, surge again, and destabilize. A blood test taken on one day may look perfectly normal. A test taken 2 weeks later might show dramatically different values. And this isn't a reason to dismiss symptoms. It's a reason to take them more seriously. The hypothalamic pituitary ovarian axis, the hormonal signaling system that governs reproductive function, responds to declining ovarian output by ramping up production of follicle stimulating hormone, FSH. The pituitary is essentially shouting louder and louder at ovaries that can no longer hear it reliably. This hyperactivation of the feedback system is responsible for many of the disruptive symptoms of perimenopause, including vasomotor symptoms, hot flashes and night sweats, mood dysregulation, and cognitive changes. Estrogen is not simply a reproductive hormone. It is a whole body signaling molecule with receptors in the brain, cardiovascular system, bones, skin, bladder, and genitourinary tissues. When its levels become chaotic, the effects are systemic. So why this happens when it does? From an evolutionary standpoint, human females are unusual among mammals in experiencing a defined reproductive endpoint while still living robust, productive lives. The evolutionary theories around this are fascinating, ranging from the grandmother hypothesis, the idea that post-reproductive women provide crucial social and survival support for their offspring's children, to more recent data suggesting that menopause may confer neurological and cognitive advantages in later life. What we do know is that the perimenopausal transition is not a malfunction. It's a programmed biological shift with real physiological intelligence behind it. The problem is not the transition itself. The problem is that modern culture has offered women very little preparation for it, and almost none for their partners. Table 1 shows you the perimenopausal timeline at a glance, where you'll start to see the timing associated with the hormonal changes and the common symptoms. Take a look. Chapter 2, the physical changes inside a body in transition. The physical symptoms of perimenopause are among the most well documented in medicine, and yet they remain among the most misunderstood in daily life. For a man or a woman trying to understand his partner, knowing the mechanism behind each symptom changes everything. Symptoms stop seeming random or exaggerated and start making sense as the logical output of a biological system under significant stress. Hot flashes and night sweats are the signature symptom of the menopausal transition, affecting approximately 75% of women in Western populations. They are sudden, intense sensations of heat that begin in the chest or face and spread outward, often accompanied by flushing, perspiration, and a brief but measurable spike in skin temperature. They typically last between 1 and 5 minutes, though some women report prolonged episodes. Night sweats are hot flashes that occur during sleep, and they're frequently severe enough to soak sheets and require a change of clothing. The mechanism is thermoregulatory. Estrogen plays a key role in stabilizing the hypothalamic thermostat, the brain's core temperature regulator. When estrogen fluctuates unpredictably, the thermoneutral zone, the temperature range within which the body does not need to generate or dissipate the heat, narrows to near zero. Tiny fluctuations in core temperature that would never register in a reproductively stable woman trigger a full heat dissipation response. This is not metaphorical heat. This is the body activating its cooling mechanisms involuntarily and at maximum intensity. For the partner sharing a bed with her, she is not dramatic. She is genuinely physiologically overheating. The sleep disruption that results from repeated nighttime events has downstream consequences for cognitive function, emotional regulation, mood, and cardiovascular health that compound over months and years. Sleep disruption. Sleep architecture changes significantly during perimenopause, not only because of night sweats. Estrogen and progesterone both contribute to sleep quality independently. Progesterone has sedative properties and promotes non-REM sleep. As progesterone declines, women frequently lose their ability to fall asleep efficiently and to stay asleep through normal early morning wakening windows. Estrogen's role in serotonin and GABA signaling, two neurotransmitters that are centrally involved in sleep regulation, means that its variability directly disrupts sleep quality at a neurochemical level. Chronic sleep deprivation at this level, many perimenopausal women experience, is not a lifestyle issue. It is a medical condition with measurable effects on memory, decision-making, immune function, pain sensitivity, and emotional resilience. Understanding changes how a partner should interpret irritability, forgetfulness, or emotional intensity. Weight distribution and metabolic shift. Many women notice, often with considerable frustration, that their body composition changes during perimenopause in ways that do not respond to the approaches that worked before. Adipose or fat tissue redistribution from peripheral hips and thighs to central abdomen deposits is a well-documented consequence of declining estrogen. Estrogen plays a significant role in lipid metabolism, insulin sensitivity, and adipokinin signaling. As its levels fall, the risk of insulin resistance increases and visceral adiposity, fat around the internal organs, accumulates more readily. Metabolic rates also shift. Muscle mass tends to decline with age in both sexes, but in women, this process accelerates around menopause, in part because estrogen has anabolic building properties. The body that was maintaining the same weight on the same diet for 20 years may no longer respond the same way. This is not a failure of discipline, it's a biological reconfiguration. Joint pain, skin changes, and hair. Estrogen has potent anti-inflammatory effects and plays a role in collagen synthesis. Its decline is associated with increases in joint pain and stiffness, thinning of the skin, changes in skin elasticity, and alterations in hair density and texture. These symptoms are frequently overlooked or attributed to aging generally, but their timing in relation to the perimenopausal transition is not coincidental. Cardiovascular and bone health. Before menopause, women have significantly lower rates of cardiovascular disease than men of the same age. Estrogen's vasodilatory, anti-inflammatory, and lipid-modifying effects confer meaningful cardiac protection. In the years surrounding menopause, that protection begins to erode. LDL cholesterol rises, HDL may decline, and arterial stiffness increases. By a decade post-menopause, a woman's cardiovascular risk profile is comparable to that of a man the same age. Bone density loss, which can ultimately lead to osteoporosis, also accelerates during and after menopause. Estrogen is essential for maintaining bone remodeling balance, and its decline shifts the equation toward net bone loss. A woman can lose up to 20% of her bone density in the 5 to 7 years following menopause. This is a long-term health issue with profound consequences, and it begins in perimenopause. Chapter 3, the psychological landscape. Her brain is not betraying her. If partners underestimate the physical changes of perimenopause, they catastrophically underestimate the psychological ones. The brain is one of the most estrogen-sensitive organs in the body. Estrogen receptors are found throughout the limbic system, the emotional processing center, the hippocampus, the memory formation, the prefrontal cortex, the executive function and emotional regulation center, and the amygdala, the threat detection and fear response. When estrogen fluctuates wildly, as it does through perimenopause, brain chemistry follows. Mood dysregulation. The relationship between estrogen and serotonin is one of the most important things a partner can understand. Estrogen upregulates serotonin synthesis, increases the density of serotonin receptors, and slows the reuptake of serotonin in the synapse. In plain terms, estrogen makes the brain serotonin system more efficient. When estrogen becomes erratic, so does serotonin signaling, and the result is a vulnerability to mood swings, irritability, sadness, and anxiety that is neurochemical in origin. Women with no prior history of mood disorders frequently experience depressive symptoms for the first time during perimenopause. Women with a history of premenstrual syndrome or postpartum depression are at significantly elevated risk of perimenopausal mood disruption because all three conditions share a common vulnerability: sensitivity to estrogen fluctuations and their downstream effects on mood chemistry. This is not a weakness, it's biology. And the practical implication for you is clear. When she cries without a clear external reason, when she moves from laughter to anger in a way that feels disproportionate to the trigger, when she seems unreachable or deeply sad on days when nothing obvious has happened, this is likely neurochemical, not interpersonal. Your first response should just be presence, not problem solving. Anxiety. Anxiety is one of the most commonly reported yet under-recognized symptoms of perimenopause. Estrogen modulates GABA receptors, which are the primary inhibitory system of the brain. Think of GABA as the biological brake on anxiety. Declining and fluctuating estrogen can compromise GABAergic tone, leaving the nervous system more excitable and less able to regulate its own fear responses. The result is generalized anxiety, sudden onset panic, hypervigilance, and a sense of dread or unease without identifiable cause. Many women in perimenopause are evaluated for anxiety disorders or prescribed anxiolytics without any recognition that the root cause is hormonal. This is a widespread failure of medical practice. For you as a partner, knowing this means not dismissing her anxiety as overthinking and not becoming impatient when she worries about things that seem small. The signal in her brain is sending is real. The volume on that signal has been turned up by estrogen withdrawal, not by irrationality. Cognitive changes in memory. Perhaps the most frightening symptom for many women is cognitive changes. Memory lapses, difficulty word finding, an inability to hold multiple tasks in mind simultaneously, and a general sense of mental fog are all documented features of the perimenopausal transition. The medical term is cognitive complaints, and they are reported by up to 60% of perimenopausal women in some research populations. Estrogen has neuroprotective properties, including effects on cerebral blood flow, mitochondrial functions in neurons, and the clearance of amyloid beta, the protein that's associated with Alzheimer's disease. Its decline during perimenopause represents a period of increased neurological vulnerability. Several longitudinal studies, including the SWAN study, the study of women's health across the nation, have documented objective declines in processing speed and verbal memory during perimenopause that partially recover in postmenopause as the hormonal environment stabilizes. When she cannot find a word she uses every day, when she walks into a room and cannot remember why, when she tells you she feels stupid or fears she's developing dementia, believe her that the experience is real and distressing, and reassure her that for most women, these cognitive changes are transitional. They are also in many cases treatable. Identity and self-concept. Perimenopause is not only a hormonal event. It arrives at a time of life often already weighted with significant psychological transitions. Children leaving home, aging parents requiring care, career reckoning, mortality awareness. The biological upheaval of perimenopause intersects with these existential questions in ways that can make the transition feel destabilizing at the level of identity. Reproductive identity, even for women who never wanted children or who are done with childbearing, is often more psychologically interwoven with a woman's sense of self than either she or her partner have previously recognized. The transition out of it can feel like grief, and it is worthy of being treated as such. She may not know who she's becoming. She may be renegotiating what she wants, what she's willing to accept, and who deserves her time and energy. These renegotiations are healthy, necessary, and sometimes uncomfortable for people around her. Your job's not to help them. Your job is to stay present while they happen. Chapter 4, Sex, Desire, and Intimacy. The honest conversation most couples avoid. Sexual changes in perimenopause are real, medically significant, and almost universally under-discussed in couples. Many couples navigate this territory through silence, and silence reliably produces misunderstanding, hurt, and distance. What follows is direct information that you can use. Genitourinary syndrome of menopause. Genitourinary syndrome of menopause, GSM, is the contemporary medical term for the complex of vulvovaginal and lower urinary tract changes that result from declining estrogen. It affects an estimated 60% of postmenopausal women to a clinically significant degree, but its onset frequently begins during late perimenopause. Unlike hot flashes, which often improve over time even without treatment, GSM is progressive. Without intervention, it worsens. The vaginal epithelium lining tissue is profoundly estrogen dependent. In the presence of adequate estrogen, it's thick, rugated, folded for elasticity, well lubricated, and acidic in pH, which protects against infection. As estrogen declines, the epithelium thins, loses its folded architecture and produces less lubrication, and becomes more alkaline and fragile. The labia minora and majora, the outer lips, lose volume and elasticity. The vaginal opening may narrow. The clitoris may experience some degree of reduced engorgement capacity. The practical consequences are significant. Penetrative sex that was previously pleasurable can become uncomfortable, painful, or impossible. Arousal might take longer. Natural lubrication may be insufficient regardless of psychological arousal. Micro tears during intercourse can cause postcoital bleeding and soreness. Recurrent urinary tract infections and urgency incontinence are associated symptoms. If your partner has withdrawn from sexual activity or seems tense or avoidant when physical intimacy is initiated, GSM is one of the first possibilities to consider. This is not disinterest in you. This is a physiological condition that makes the activity painful, and most women are too embarrassed, too tired of not being believed, or too uncertain whether it's medically addressable to bring it up. Libido. Desire is not a simple variable. It's the product of hormones, neurotransmitters, sleep quality, stress load, emotional safety, relationship history, body image, pain, and mental bandwidth. Perimenopause interferes with nearly all of these simultaneously. Testosterone, which plays a significant role in female libido, often more so than estrogen, also declines through the perimenopausal years, reaching roughly half of its peak premenopausal level by the early postmenopausal period. Low testosterone in women is associated with reduced spontaneous desire, reduced frequency of sexual thoughts, and decreased capacity for arousal. This is a physiological change, not a reflection of how she feels about you. It's also worth understanding the distinction between spontaneous desire, the kind that arrives without a specific stimulus, and responsive desire, the kind that emerges in response to arousal. Many women, particularly with young children, high stress loads, or history of trauma, have always experienced primarily responsive desire. For others, perimenopause shifts the balance. Responsive desire is not lesser desire. It simply means that the context and initiation need to be different. So she may be more open to your initiation, but she might not be the one initiating. The worst thing you can do is take reduced libido personally and respond with withdrawal or pressure. These responses reliably suppress whatever responsive desire is available and add a layer of relational anxiety on top of physiological challenge. The most effective thing you can do is reduce pressure completely, increase non-sexual physical affection, and stay curious about what does feel good, what she needs in the bedroom now. More time, more lubrication, more warmth and safety, more verbal communication, and less performance pressure for both of you. The physiology of arousal in a perimenopausal or postmenopausal woman requires more time than it did in her 30s. The engorgement response is slower. Lubrication may be incomplete regardless of how aroused she is subjectively. Use a high-quality lubricant, nothing with fragrances or heating properties. If Uberlube would ever sponsor me, I would tell everyone to use it. Oops, too late. I tell everyone to use it anyway. Vaginal hormones like vaginal estrogen or vaginal DHEA, progesterone, or a compounded estrogen testosterone cream may be critical to reducing pain. A vaginal moisturizer, especially in the winter months for those who live in the north, used regularly, plus a lubricant during sexual activity is not a signal that something's wrong. It's appropriate, evidence-based care for a tissue that's no longer self-maintaining the same way. Many couples who engage openly with these changes report that the communication skills they develop navigating perimenopause produce the best sex of their relationship. That's not universally true, but it is reliably possible when both partners approach the territory with honesty and without blame. Chapter 5. What you can actually do. A partner's practical guide. This chapter is where good intentions meet applied action. Everything you've read so far is preparation for this. The concrete, evidence-informed things that you can do to be a better partner through one of the most significant transitions of her life. Learn the language before the conversation. The single most important preparation you can make is reading this document and others like it before her symptoms become a crisis. Most partners arrive at understanding perimenopause reactively. After conflicts, after distance, after she's spent months feeling alone in what she's experiencing. You've already begun doing the right thing. Keep going. Talk to her about what you're learning. Not in a clinical, I have diagnosed your situation way, but in a way that signals you've been paying attention. The sentence, I've been reading about perimenopause because I want to understand what you're going through, is worth more than most gestures you could make. Create a low inflammation environment. Her nervous system is already working overtime. The single most important thing you can contribute to the atmosphere of your shared life is reducing friction and ambient stress wherever you can. This is not about walking on eggshells. It's about taking responsibility for your share of the domestic and logistical load with more initiative and less requests for direction. Research consistently shows that cognitive labor, the invisible work of remembering, planning, and coordinating household and family life, falls disproportionately on women, even in relatively egalitarian partnerships. A perimenopausal woman, who is also the cognitive manager of the household, carries a burden that compounds her neurological system. If she is tracking appointments, managing social calendars, remembering who needs what when, and also experiencing cognitive fog, sleep deprivation, and anxiety, take things off the list. Not because she can't handle them, but because she shouldn't have to. Attend a medical appointment with her. This is one of the highest value actions available to you. Hormonal and perimenopausal health remains an area where many women report being dismissed, undertreated, or given insufficient information by clinicians. Having a partner present who's informed and supportive changes that dynamic. It signals that her health is a shared priority. It doubles the capacity for questions and information retention. It communicates to her unmistakably that you are in this with her. If she has a physician or a provider she trusts who specializes in menopause care, look for the Menopause Society certified practitioner. Support her in accessing that care. If she's hesitant to pursue medical evaluation, understand that this hesitance often comes from years of having her symptoms minimized. Encourage her gently. Do not pressure. Do not diagnose. Be the person sitting next to her in the waiting room. Take sleep seriously. The shared bed during perimenopause often becomes a contested terrain. Night sweats require immediate response. A cooler room, 65 to 68 degrees Fahrenheit is optimal for most perimenopausal women, moisture wicking bedding, and the option to sleep in a lighter layer. If her night sweats are severe, sleeping in separate beds temporarily is not a rejection. It's a reasonable accommodation of a medical symptom, and couples who manage it as such with explicit conversation and continued daytime intimacy typically navigate it without relational damage. You should also take her insomnia seriously as a medical matter. Chronic sleep deprivation of this type, many perimenopausal women experience as a health hazard. Support her in discussing it with her provider. In the meantime, do not make noise, light, or schedule demands that compromise her ability to sleep when the opportunity is there. Support. Do not direct her medical treatment decisions. Menopausal hormone therapy, MHT, formerly known as hormone replacement therapy, is one of the most effective treatments available for perimenopausal and menopausal symptoms, and it remains one of the most politically and medically fraught. The 2002 Women's Health Initiative study, which reported elevated risks of breast cancer and cardiovascular events with a specific oral combination therapy, created a generation of medical hesitancy around hormones that current evidence suggests was significantly overcorrected. Contemporary data, including analyses by the Menopause Society and the British Menopause Society, support the use of menopause hormone therapy for healthy, symptomatic women under 60 or within 10 years of menopause onset. For many women, the risks of undertreated menopause, including cardiovascular disease, osteoporosis, cognitive decline, and impaired quality of life, outweigh the risks of appropriately prescribed hormone therapy. This is her body and her decision. Your role is to support her in having an informed conversation with a knowledgeable provider, to not inject fear or skepticism based on outdated information, and to respect whatever decision she makes after that informed consultation. If she decides to try hormone therapy, support it. If she decides not to, support that too. There are effective non-hormonal options, and the treatment approach is appropriately individualized. Protect the relationship. Perimenopause is a significant stress test for long-term partnerships. The research on relationship satisfaction through the menopausal transition is sobering. Dissatisfaction peaks during the perimenopausal years and frequently prompts separation in couples who are already experiencing underlying strain. But the data also show that couples who navigate perimenopause successfully often report greater intimacy, improved communication, and stronger mutual respect in the years that follow. The difference between these two outcomes is largely whether both partners engage the transition as something happening to them together, or whether the man or woman treats it as something happening to her alone that he or she must simply endure. The first framing produces partnership. The second produces resentment on both sides. And yeah, I haven't spent that much time talking about if both of you are women and both of you are going through perimenopause. That could be really tough, but it also could be really helpful that you could lean on each other to get through this difficult time. Consider couples therapy during the perimenopausal years, not as a crisis intervention, but as a proactive investment. A skilled therapist can provide a space to process the relational shifts that perimenopause generates, including changes in sexual frequency, emotional availability, household dynamics, and identity renegotiation before they calcify into distance. Words matter more during perimenopause. When her nervous system is hypervigilant and her emotional processing is neurochemically altered, the following table is not about scripts. It's about the underlying stance. Every phrase in the left column signals this is your problem. Every phrase in the right column signals we are in this together. So instead of saying, you're being so emotional about this, maybe try saying, I can see this is hard. I'm not going anywhere. What not to say? Is it your hormones again? What to say instead? What does support look like to you right now? What not to say? You used to want sex all the time. What to say instead? I want to feel close to you. Can we talk about what feels good? What not to say? Other women don't seem to make this a big deal. What to say instead? Tell me more about what this has been like for you. What not to say? Maybe you should just exercise more. What to say instead? Have you talked to your doctor? I'll come with you if you like. What not to say? I feel like I don't know you anymore. What to say instead? I'm learning alongside you. I'm committed to figuring this out together. Chapter 6, the medical toolkit. What is available and how to help her access it. Understanding the treatment landscape for perimenopause allows you to be a more useful advocate and a more informed conversation partner when she discusses options with her physician or provider with you. Menopausal hormone therapy. For women with significant vasomotor symptoms, mood disruption, GSM, or elevated risk of bone loss and cardiovascular disease, menopausal hormone therapy is often the most effective intervention. Modern MHT is available in multiple formulations, including transdermal, patches, gels, sprays, and even vaginal rings, tablets, creams, preparations that avoid the first pass liver metabolism associated with older oral formulations. This distinction matters. It is largely oral equine estrogen combinations, not transdermal bioidentical preparations, that carry the risk profile from the Women's Health Initiative data. Localized vaginal estrogen used for GSM specifically is extremely low dose, has minimal systemic absorption, and is considered safe for nearly all women, including most breast cancer survivors, according to current major menopause society guidelines. If she's experiencing painful sex or recurrent UTIs and has been told there's nothing to be done or that she cannot take hormones, she may benefit from a second opinion from a menopause specialist. Non-hormonal options. For women who cannot or choose not to use hormone therapy, several evidence-based options exist. Fezolinetant, a neurokinin 3 receptor antagonist approved in 2023, and elezanitant, a neurokinin 1 and 3 antagonist approved in 2025, represent non-hormonal mechanisms for reducing hot flash frequency and severity. Paroxetine, a selective serotonin reuptake inhibitor, is FDA approved for vasomotor symptoms at low doses. Other SSRIs and SNRIs have supporting evidence without formal indication. Cognitive behavioral therapy has demonstrated efficacy for hot flash frequency and for sleep and mood components of perimenopause. For GSM specifically, over-the-counter vaginal moisturizers used regularly, not only during intercourse, can meaningfully improve tissue health and comfort. High-quality lubricants used during sexual activity reduce friction and trauma. Pelvic floor physical therapy performed by a specialist physical therapist can address pelvic floor dysfunction, pain with intercourse, and urinary symptoms that are common in the menopausal transition. Lifestyle factors with genuine evidence. Resistance and weight-bearing exercise is among the most impactful interventions available for perimenopausal women. It preserves muscle mass, supports metabolic function, protects bone density, improves sleep architecture, and has meaningful effects on mood through endorphin and brain-derived neurotrophic factor pathways. If you exercise, inviting her into your routine without pressure and with genuine flexibility about format and pace is one of the most concrete health supports available. Dietary approaches that reduce glycemic load, prioritize lean protein, and emphasize phytoestrogen-containing foods like soy, flaxseed, legumes have modest supporting evidence for symptom management. Alcohol exacerbates hot flashes, disrupts sleep architecture, and worsens mood dysregulation. She might already know this. Support her in whatever adjustments she's trying to make by not placing alcohol at the center of your social life. Stress management is not a soft intervention. Cortisol, the primary stress hormone, competes with progesterone at the receptor level and exacerbates the hormone volatility of perimenopause, supporting her capacity to rest, to have unstructured time, and to not be the default parent, manager, planner in your household is a direct medical intervention, even if it doesn't feel like one. Chapter 7, The Long Game. Who she is becoming. Perimenopause ends. Menopause, that quiet landmark of 12 months without a period, arrives. And most women, after the transition stabilizes, describe a postmenopausal self with qualities she values: clarity, directness, a recalibrated sense of priority, and a considerably reduced tolerance for what does not serve her. This is sometimes called the postmenopausal zest, a term coined by anthropologist Margaret Mead to describe the vitality and freedom that many women experience on the other side of the transition. It is real and it is documented. Research consistently shows that life satisfaction scores in women often rise in the years following menopause after the perimenopausal trough, sometimes to the highest level of their adult lives. The woman who comes through perimenopause often has a clearer sense of herself than she has had at any other point in her life. She has survived a biological transition that tested her on every dimension: physical, cognitive, emotional, relational. The things she kept through that, including the relationship she invested in, the partner who showed up, the work she found meaningful, become more precious, not less. You're not waiting for her to return to who she was. She's not going back. You are watching someone become more completely herself, and your role in this transition will be remembered. Partners who engaged, learned, showed up, and held steady are partners who remain. Partners who waited for the storm to pass on its own, who minimized, who made the transition about their inconvenience, are partners who frequently find they've been evaluated and found insufficient. This is not a threat. It's an honest description of what happens when the neurochemical fog lifts and a woman who's been underserved by her support system has the cognitive clarity to see it. A final word. You came to this book because you care. That matters. Love in the abstract is less useful than love applied with knowledge. And you've begun to do the work of making your love more useful. Keep going. Ask questions, read more. Follow her medical care with interest. Show up in the small moments, not only in the large ones. Take things off her plate. Say the right things, and when you say the wrong things, because you might, repair it quickly and without defensiveness. She's not broken. She's not difficult. She's not someone you need to manage or protect yourself from. She is a woman in the middle of one of the most profound biological events of human life, doing her best and hoping you'll meet her there. You can, and you will. If you would like to have more resources and references, please find a Menopause Society certified practitioner at menopause.org/find-a-provider. If you want more information on menopause itself, you can check out the Menopause Society, which was formerly called NAMS. You can check out the British Menopause Society clinical guidelines. I'd love to point you in direction of a book I wrote with my colleagues called Love, Sex, and Menopause. You can continue to follow my podcast, ourwomanity.com. And you can follow me at Dr. Rachel Pope on Instagram. You can check out more of my podcasts on YouTube, Spotify, and Apple Podcasts.